Hello friends, welcome back to my YouTube channel, that is ENT Chronicle, and today we're going to be discussing about the malignancy of the maxillary sinus. Alright, so this person right here is suffering from maxillary carcinoma, and one thing to remember is carcinoma of the maxillary sinus is the most common site for malignancy in whole of paranasal sinuses. Alright, so most common site for malignancy in PNS is maxillary sinus. It's a potential MCQ. Alright, and carcinoma of maxillary sinus happens in around 4th to 6th decade of life. Alright, it typically seen in the middle and old age individuals, and there is a certain male predominance in the incidence. Alright, males are often more affected than females. There is a ratio of 4:1, that is 4 males are affected in lieu of 1 female. Alright, now let's see what is the etiology for maxillary sinus carcinoma. All these points are highly important in the etiology of maxillary carcinoma. So first we have people working in the nickel and chromium industries or somehow exposed to nickel and chromium products. So this is the buzzword for any history that has to be given in the question, right? That a 45-year-old male has been working in nickel and chromium industry, present with this swelling, and what is the probable diagnosis? So this is the buzzword for maxillary sinus carcinoma. That is, the person is working in nickel and chromium industries. So if the person works in the nickel or chromium industry, the type of cancer that he will develop in maxillary sinus would be squamous cell carcinoma. Very important point. But if the person is a woodworker, he works in the wood industry, then the most probably the carcinoma that he'll develop in the maxillary sinus would be of adenocarcinoma type. All right, if working in nickel and chromium industry, the carcinoma would be of squamous cell type, whereas if he's a woodworker, the carcinoma would be of adenocarcinoma type. All right, there's also etiology by a dye known as the thoras dye. All right, along with exposure to irradiation, especially treatment of retinoblastoma in children. All right, treatment of retinoblastoma in children. Another etiology is seen in people synthesizing the mustard gas. All right, makers of mustard gas often suffer from various carcinomas, including maxillary sinus carcinoma. But you have to remember these two these two in every single point. Alright, that is, people working in nickel and chromium industries would lead to squamous cell carcinoma, and woodworkers would lead to adenocarcinoma. Alright, now let's see the types of maxillary neoplasms. See, we have seen that there is carcinoma in the maxillary sinus. That carcinoma can be of carcinoma type, it can be sarcoma type, it can be a odontogenic tumor or some other carcinomas. Alright, so the first neoplasm is formation of carcinoma in the maxillary sinus. We have the squamous cell carcinoma, adenocarcinoma, adenoid cystic carcinoma, and anaplastic carcinoma. Alright, in sarcomas, if the neoplasm in the maxillary sinus is a sarcoma, it may be chondrosarcoma, fibrosarcoma, or osteogenic sarcoma. Whereas if it's an odontogenic tumor, it might be an ameloblastoma or odontoma. Others include melanoma and lymphoma. You don't have to remember this whole classification. All you need to remember is that in around 80% of cases, the neoplasm involved in maxillary sinus carcinoma is squamous cell carcinoma. Alright, and that is most common neoplasm that happens in maxillary sinus is squamous cell carcinoma, followed by adenocarcinoma. Alright, then it is followed by melanoma. You just have to remember this line, that is, most common is squamous cell carcinoma, then second most common is adenocarcinoma, and third most common is melanoma of the maxillary sinus. So melanoma of the maxillary sinus. Now let's talk about the clinical features. All right, so let me explain the clinical features with the help of this diagram. So this is the maxillary sinus right here. All right, this is the maxillary sinus. Now suppose somehow there is growth of tissue in the maxillary sinus. That is, there is carcinoma in the maxillary sinus. Now, this carcinoma may aggravate in superior direction. It may extend superiorly. It may extend laterally and anteriorly. It may extend inferiorly, and it may extend medially. A different extension in different sides would lead to different signs and symptoms. All right. So let's start with if the tumor gets aggressive and extends in the superior direction, that is, it moves towards the orbit. So if it moves superiorly, it would lead to proptosis, diplopia, blindness, and ophthalmoplegia. It's very simple to remember. If below the orbit, we have the maxillary sinus, right? If the tumor moves upwards towards the orbit, it will definitely lead to blindness, proptosis, diplopia, and ophthalmoplegia. All right. So if it moves superiorly, we see these features. If the tumor moves anterolaterally, all right, it moves in the lateral and anterior direction. First of all, it will lead to cheek swelling, involvement of the skin, and typical paresthesia over the cheek. All right. So cheek swelling would be the typical history that would be given in the question. So cheek swelling, I've added the image as well. See, you guys could see if it travels anterolaterally, the tumor, it will lead to cheek swelling involving the skin as well, and paresthesia over the skin of cheek. All right. Now, if the tumor move medially, that is towards the nasal cavity, what would it do? It would lead to epistaxis, nasal discharge, and anosmia. All right, very simple to remember. If it moved towards the nasal cavity, what are the typical sign and symptom that it would produce in the nasal cavity? That would be epistaxis, nasal discharge, and anosmia. All right. If the tumor extends inferiorly in the downwards direction, what is just below the maxillary sinus, we have the alveolar process hosting teeth. So if the tumor extends inferiorly, it will lead to loosening of teeth, dental pain, and after that it will lead to oral spread. All right, very simple. Superiorly, it affecting eyes. Anterolaterally, it affecting the cheek. Inferiorly, it is affecting the upper jaw, that is loosening of teeth, dental pain, oral spread. And if it goes medially, it affects the nasal cavity, epistaxis, nasal discharge, and anosmia. All right. And what would the features be present in the question? There would be cheek swelling, epistaxis, and loosening of teeth and dental pain. So this will become the typical history in the case of maxillary sinus carcinoma. All right. So the only thing left is posteriorly. If the tumor moves posteriorly from this direction, just behind the maxillary sinus, we have the two lateral and the medial pterygoid plates. If the tumor moves posteriorly, it will involve the pterygoid muscle and would lead to formation of trismus. Alright, so trismus is also seen in later stages of maxillary sinus carcinoma. Now, what is the spread of malignancy? Just like any other malignancy in the human body, there can be local spread. I've already discussed about the local spread. This is all the sign and symptom produced due to local spread of the tumor. All right. We can have local spread, lymphatic spread, and hematogenous spread. Hematogenous spread is the most dreaded and the dangerous one. All right. One thing you have to remember about the clinical features of maxillary sinus carcinoma is that it remains silent for a very long time. That is, diagnosis is made in the very later stages. And this is because the patient just complains vague symptoms of sinusitis for a very long time. So practically the patient is getting treatment for sinusitis and he doesn't know that there is a mass growing in his maxillary sinus. Therefore, you have to remember this point, that it remains silent for a very long time. That is, it is diagnosed in very later stages because of presence of vague symptoms of sinusitis for a longer period of time. All right. Next, we have if the tumor is in pterygopalatine fossa, it reaches pterygopalatine fossa. From here, it may reach the middle cranial fossa through the foramen rotundum. All right. This tumor can reach to foramen lacerum through the pterygoid canal. This tumor can reach the orbital apex through the inferior orbital fissure. This tumor can reach the nasopharynx through the sphenopalatine fossa. And if the tumor is in pterygopalatine fossa, it would directly reach into the infratemporal fossa. All right, you just have to remember these facts. These facts are valid for other carcinomas as well. You just have to remember, if it is entering the middle cranial fossa, it is to foramen rotundum, and if it is entering foramen lacerum, it is to pterygoid canal. If it is entering into orbital apex, it is entering to inferior orbital fissure. It is directly entering into the infratemporal fossa, and through sphenopalatine fossa is going into the nasopharynx. It is happening only because if there is presence of tumor in the pterygopalatine fossa. All right. Now, let's talk about various classifications given to classify the maxillary sinus carcinoma. So, first and the most classic one of them all is Ohngrens classification. Alright, Ohngrens classification basically talked about the prognosis of maxillary sinus carcinoma. So, Ohngrens suggested, so what Ohngrens did is he drew a line from the medial canthus of eye to the angle of mandible. All right, he draw this diagonal line from medial canthus of eye to angle of mandible, and the part of maxillary sinus above this line is known to be as the suprastructure, whereas the part of maxillary sinus below this line is referred to as the infrastructure. So Ohngrens just suggested that any tumor present above this line, that is in the suprastructure, it's going to have bad prognosis. It's going to have bad prognosis. All right. Now, if the tumor is below this Ohngrens lines, that is, it is present in the infrastructure, it has comparatively better prognosis. All right, it has comparatively better prognosis. So this was the only thing that was talked in by Ohngrens classification. That is, if the tumor is present above Ohngrens line, it is going to be having bad prognosis. If the tumor is present below the Ohngrens line, it is going to have good prognosis. Now came the Lederman. So what Lederman did was he drew 4 set of lines. That is 2 horizontal lines and 2 vertical lines. One thing to remember is these 2 horizontal lines are known to be line of Sebileau. Alright, these are known as lines of Sebileau. So 2 horizontal lines, but first horizontal line was drawn at the base of orbit. Next horizontal line was drawn at the base of sinus, that is the antral base. Alright, at the base of antrum and at the base of orbit. These lines are referred to as the line of Sebileau. Whereas 2 vertical lines are drawn through the medial canthus downwards. So from the medial canthus downwards. Alright, so this divides in the paranasal sinuses into the suprastructure, mesostructure and infrastructure. Alright, and what are the possible spread areas included in suprastructure are ethmoid, sphenoid, frontal sinus, olfactory area of the nose. Alright, so in suprastructure we have involvement of ethmoid, sphenoid, frontal sinus, olfactory area of nose. In the mesostructure, between the 2 horizontal lines, we have maxillary and respiratory part of the nose. And finally, in the infrastructure, we have the alveolar process, basically the teeth. So Lederman's classification, this is the significance of Lederman's classification. You don't have to remember this, it's just for additional information. The Lederman classification was more prognostic for loco-regional control and disease-specific survival. It was even better than the TNM classification. And along with this, Lederman classification was easy to use and has a broader applicability as it covers all the sites in the sinonasal area. Alright. Basically, Ohngrens just said if it is up, it is bad. If it is down, then it is good. But Lederman divided entire paranasal sinuses into various segments. So these segments you covered all site in sinonasal area. That's why the classification of tumor spread became much more easy. Just remember Lederman classification: 2 horizontal line, these are, and 2 vertical. These 2 horizontal are known as line of Sebileau and divides into supra, meso and infra. Alright, and these are the sites of involvement in various locations. All right. Now the more important one is the TNM staging, the dreaded TNM staging. So TNM staging of almost all carcinomas are very difficult to remember, but I have simplified for this one. So T stands from tumor, N for node, and M for metastasis. We will discuss all three of them. First, we have the tumor. So staging of tumor is done T1, T2, T3, T4A, and T4B. And if we move from above downwards, there is increase in uh, spread. That is, it's spreading, increase in erosion, decrease in prognosis. All right, so this is happening. You have to remember these lines because they are very specific in nature. All right, T1 is tumor is limited to the maxillary sinus, as well as there is no erosion of any bone. All right, very simple. T1 only present in the maxillary sinus and there is no bone erosion. T2 now it starts to spread. Tumor causes bone erosion. All right, and there is extension to hard palate and or middle meatus. All right, through the meatus, through the foramen, it's coming into the middle meatus or node. So T1 was tumor limited to the maxillary sinus, no erosion. In T2 there is erosion and there is extension to hard palate or middle meatus. Now, if it in T3 we have, if the tumor invades any of the posterior maxillary wall, either it invades the orbit, either it invades the pterygoid fossa, either it invades the ethmoid sinus. So if the tumor invades any of these, it directly comes into T3 staging of in TNM staging. All right, T4A, T4B. If the tumor invades orbital contents, so tumor was invading orbit in T3, right? And in T4A it starts invading the orbital contents, that is optic nerve and the eye itself. Invasion of cheek, invasion of pterygoid plate, invasion of cribriform plate. So T3 was invading pterygoid fossa and T4A it is invading pterygoid plate. It is also invading cribriform plate, sphenoid and frontal sinus. In T3, which sinus was getting invaded? That was ethmoid sinus, whereas T4A, sphenoid and frontal sinuses are getting invaded. And finally, T4B is the most dreaded one, least of worst prognosis. So if the tumor invades dura mater, that is the tumor has reached the brain, part of brain, it invades cranial nerves, it invades middle cranial fossa or cleavus, then it is referred to be in T4B stage. All right. Now let's start with the lymph node, that is N. If it is said to be N0, that is no nodal involvement is seen. But node is divided into N1, N2A, N2B, N2C and N3. Alright, it is very easy to remember. In fact, this nodal classification, N classification in TNM is valid for almost every single malignancy of head and neck. Alright, so if you remember this right here, then it will be super easy for you to remember the other malignancies as well. Alright, N1 is if that size of node is less than or equal to 3 centimeter. There is a single lymph node involvement on the same side. Alright, now N2A, N2B, N2C. Very simple. Size more than 3 but less than 5. More than 3, less than 5. More than 3, less than 5 of the lymph node. In N2A, there is a single lymph node present ipsilaterally. In N2B, there are multiple lymph nodes but still they are present on the same side. Alright. In N2C, there are multiple lymph nodes but they are bilaterally present. Alright. And N3 is just simple. If any lymph node increases to a size more than equal to 6 centimeter, it directly comes into the N3 stage of node. Alright, very simple. So N1 was less than equal to 3 centimeter, single ipsilateral. All the data is same here, N2, N2B and N2C, that is more than 3 and less than 5. N2A is single and ipsilateral, N2B is multiple and ipsilateral, and N2C is multiple bilateral, basically decreasing prognosis and increasing of spread. All right, and finally n3 is increase if any node has size greater than equal to 6 centimeter, directly comes into n3. All right, m is very simple. M0 there is no metastasis. If it is n1 there is distant metastasis. All right, now this is very important to remember, that is a stage grouping. All right, so treatment is based on stage grouping, all right, and not on TNM classification itself. So what is stage 0 of malignant maxillary sinus carcinoma? That is TIS. TIS means carcinoma in situ. The carcinoma has not yet invaded the basement membrane. All right, stage 0 T, we have carcinoma in situ, there is no lymph node involvement, there is no metastasis. Stage 1, T1 stage, there is no lymph node involved, there is no metastasis. Stage 2 is T2, there is no lymph node and there is no metastasis. All right, in fact metastasis is only seen in one, that is stage 4C, most dreaded one of them all. All right, so up till stage 2 it is very simple, right? Up to stage 2 it is very simple. First we have carcinoma in situ, then we have T1 stage and T2 stage respectively for these. There is no lymph node involvement and there is no metastasis. Now it gets a little complicated from stage 3. First of all, stage 3 we have T3. In T3 there is no lymph node involvement and no metastasis. This is the probability number 1. All right, if somehow the one of the nodes become active, that is it becomes n1, then any of these, that is along with n1, it could be either T1, it could be either T2, or it could be either T3, it directly becomes a part of stage 3. All right, similarly if any of the thing in stage 4A, that is T1, T2, T3 becomes paired with n2, all right, becomes paired with n2, it directly becomes stage 4A. And if it becomes T4A with either of n0, n1 or n2, it becomes again stage 4A. All right, next we have stage 4B. If T stage is T4B and it gets mixed with any n, all right, even n0, n1, n2, n2A, n2B, n2C and all, it becomes stage 4B. If there is any T, it gets paired with n3, all right, it again becomes stage 4B. If it is any T paired with any N along with presence of metastasis, the most dangerous one, it is referred to as stage 4C. So up till here is very simple to remember, and finally stage 4C you have already remembered. You just have to memorize, rote learn these three, that is stage 3, stage 4A, stage 4B. And one thing to remember is this stage grouping is even valid for laryngeal carcinomas. Alright, this is even valid for laryngeal carcinomas. So remember this here once and for all, and you will be sorted for laryngeal carcinomas as well. Alright, so stage grouping M and N is also valid for the laryngeal carcinomas along with maxillary sinus carcinoma. Alright. Okay, next we have how will we investigate the maxillary sinus carcinoma. First we will do something known as the contrast enhanced CT scan in the axial, coronal and sagittal planes. All right, we have to do a MRI in cases of optic nerve involvement or there is severe proptosis. All right, and then we'll do biopsy. The biopsy can be taken from both nose as well as mouth. All right, we will do an FNAC of the neck nodes. If there are presence of neck node, we will do an FNAC. So investigation include CECT, MRI, biopsy and FNAC if nodes are positive. Alright, what will we find in the CT scan of the tumor? First of all, it's going to be an homogeneous mass. There are going to be foci of hemorrhage and necrosis. There is going to be calcification just like any other malignancy. And finally, we are going to see the important finding, that is the bone erosion. So bone erosion starts just from stage T2. Alright. And two things you guys have to remember. So this is the CT scan of the person. See, this is the normal maxillary sinus, right? And here there is no set defined boundary. The tumor has spread into the nasal cavity, the tumor has spread into the oral cavity, and the tumor has eroded all the bones, there is excessive bone erosion. All right. And two things you guys have to remember. What is the earliest sign of intracranial spread in this tumor? So we have bone erosion at sinus dural interface, which is seen on CT scan. So these one word are very important for MCQ point of view. Earliest sign of intracranial spread is bone erosion at sinodural interface, seen on CT scan. And what is the earliest sign of brain invasion? Alright, so earliest sign of brain invasion is surface enhancement and localized edema of the brain surface, right, which is seen on MRI. Alright, what is the earliest sign of brain invasion? It is a enhancement and localized edema of the brain surface, which is seen on MRI. Alright, we have talked about earliest sign of intracranial spread and earliest sign of brain invasion. Now let's see another important part, that is the treatment. So as I've already mentioned that maxillary sinus carcinoma is diagnosed very late because there are vague symptoms of sinusitis in the patient for a very long time. The patient gets treated just for sinusitis and does not know that he is suffering from this malignancy. Therefore, the 5-year survival rate of this malignancy is mere 40 to 50%. That is, of all the patients treated, only around 40 to 50% are alive for 5 years. All right. So what are the treatment methodologies? First, if the person is in stage 1 and stage 2, we are talking about this. If the person is in the stage 1 and in stage 2, this portion. All right. So what we do in this, there both surgery as well as radiation can be done individually. Either you do surgery or either you do radiation. All right. What are the options available in surgery? There is inferior medial maxillectomy, there is medial maxillectomy, and next we have radical maxillectomy. All these maxillectomies are done with the help of a special incision referred to as the Weber-Ferguson's incision. You have to remember this name. All right. I've added the image. So this right here, you guys could appreciate, is the Weber-Ferguson incision seen in maxillectomy. So what is the incision in maxillectomy? It is Weber-Ferguson incision. Alright, surgery include inferior medial maxillectomy and radical maxillectomy with the help of Weber-Ferguson's incision. In radiation, pre-operatively we give 5500 centigrade of radiation, and after operation, post-operation, we give 5000 to 5500 centigrade of radiation. All right, so radiation, most important, the important one is the surgery. You have to remember the surgery more than the radiation part. Now, if there is T3 and T4 lesions, so basically we're not talking about the stage 3 and 4. We are talking about any part in which there is T3 and T4 lesion. So what we do is, there is combination of both surgery and radiotherapy. We do both of these things. Right, combination of surgery and radiotherapy. Whereas in stage 1 and 2 we were either doing surgery or either doing radiation. All right. So we combine surgery and radiotherapy in T3 T4 lesion. Surgery and radiotherapy remain same in here. All right. Now we might as well use chemoradiation for large and inoperable tumors. All right. We use chemicals like 5-fluorouracil or cisplatin in this. So chemoradiation is reserved for large, very large and inoperable tumors. All right. So let me revise the treatment once again. If stage 1 and 2, we will either do surgery or either do radiation. All right. Surgery include inferior medial maxillectomy or radical maxillectomy through a special incision referred to as Weber-Ferguson's incision. All right. If the staging contains any of the two, that is T3 or T4, we do combination of surgery or radiation. Alright, we do both together. Then we have chemoradiation. It is only reserved for very large and inoperable tumors with the help of cisplatin or 5-UE like chemicals. Alright, now there is something referred to as Barbosa technique. Barbosa technique, you just have to remember one line. It is done for if tumor in the maxillary sinus carcinoma which has infratemporal extension. All right, it is done for maxillary sinus carcinoma having an infratemporal fossa extension. You just have to remember this in Barbosa technique. All right, so this was all about the maxillary sinus carcinoma. I hope you guys liked the video. Please like, share and subscribe to my YouTube channel, that is ENT Chronicle. Thank you.